This presentation is formed of two components, fluid and electrolyte imbalances, and the second component is surgical nutrition part 1 by Dr. Hesham Akkad, Professor of General Surgery, Ain Shams Medical School. Regarding the first component, fluid and electrolyte and acid-base imbalances, by the end of this lecture, you should be able to recall the important figures related to major electrolytes and acid-base balance, explain the pathogenesis of each abnormality, describe the manifestations of each abnormality, and set a treatment plan for correction of each abnormality or mixed abnormalities. Body compartments are intracellular compartment containing about 60% of body water and the extracellular compartment. The extracellular compartment is further divided into interstitial compartment, which contains 30% of body water, and intravascular compartment, which contains 10%. Water moves freely between all compartments according to osmolality, which is the concentration of osmoles in a solution. So determining the osmolality of plasma will reflect the osmolality of the intracellular compartment. However, the osmoles that create fluid osmolality are very different from each other because osmoles do not pass freely from one compartment to another. Intracellular compartment contains, besides the anionic proteins and organic phosphates, it contains most of the body content of potassium cation in such high concentration than in the extracellular compartment. On the other hand, the extracellular compartment contains most of the body content of sodium cation, which is electrically balanced by the anions chloride and bicarbonate. The big differences in the concentrations of sodium and potassium between the two major compartments is generated by an active energy-demanding sodium-potassium pump of cell membranes. So the measurement of serum concentration of sodium does not reflect whether there is deficient or excess amount of sodium in the body, but reflects the loss of water or excess water in the body relative to sodium loss or gain. Similar to a small salty lake that lost water by evaporation, so became hypertonic, or gained water from rain, so became hypotonic relative to its original tonicity. Salt amount in this lake was the same in all cases. Sodium moves freely between the interstitial compartment and the intravascular compartment. Hyponatremia is the decrease of plasma sodium below 135 milliequivalent per liter and is classified as severe if less than 120 milliequivalent per liter. Hyponatremia reflects hypotonicity of plasma, meaning that there is relative excess of water. The exception to this condition is hypertonicity associated with hyponatremia when blood glucose reaches very high levels and starts to contribute appreciably to plasma tonicity. Normal glucose levels contribute little to extracellular fluid tonicity, where sodium is the main determinant. Fluid and electrolyte imbalances are of four types: volume and concentration abnormalities, or the mixed type of both, are all concerned with the water and sodium balance because extracellular fluid volume is formed mainly of water and sodium. Other electrolytes which are present in the extracellular fluid are very important also to be normal, but contribute little to concentration, which is osmolality and tonicity. One important electrolyte of those is potassium. Potassium imbalances are one of composition abnormalities. Pure volume abnormalities occur due to body losses of both water and sodium in the same proportions in the extracellular fluid. If the yellow is water of the extracellular fluid and the blue balls are the sodium cations in the fluid, then if we pour some of this water away, the volume of this salty water decreases, but the concentration of sodium in the remaining water is the same. So if the body loses extracellular fluid, there will be loss of volume, but the extracellular fluid remains isotonic, because the volume lost contained the same concentration of sodium as the remaining volume. The loss is called isotonic depletion or volume depletion, which results in the clinical condition known as hypovolemia. Causes of hypovolemia include all conditions where the body fluid losses are almost isotonic, that is to say, of almost equal sodium concentration as that of the extracellular fluid. Gastrointestinal juices are major isotonic fluids that are commonly lost in clinical conditions like vomiting, severe diarrhea, intestinal obstruction, and intestinal fistula. The lost fluid might exit the extracellular compartment but not the body. It might collect in ineffective spaces inside the body that do not contribute to the extracellular fluid volume. These are called third spaces. Examples are the peritoneal cavity filled with ascites, the pleura, and the dilated lumen of bowel, which fill with fluid in cases of intestinal obstruction. Third fluid losses may be much more than evident losses in vomiting, for example, so it must be accounted for when estimating the fluid needs to correct hypovolemia. Because serum sodium is normal in hypovolemia due to isotonic depletion, the estimation of the amount of losses depends largely on clinical signs and other measurements. Hypovolemia due to fluid losses shows signs resembling those of hypovolemia due to blood losses, but with hypovolemia due to bleeding, there are some differences because of the additional protein and cell component losses. This shall be dealt with in a separate lecture of hemorrhage and shock. This slide shows signs of mild hypovolemic shock and the estimated volume loss with these signs. This slide shows the signs of severe hypovolemic shock and the estimated volume deficit with these signs. Moderate shock is in between. Estimated losses are compensated for by isotonic salt solutions. Note that the term salt means sodium chloride. Ringer's lactate is another isotonic salt solution with little less concentration of sodium but little amount of potassium in addition. The lactate makes the solution less acidotic than normal saline. The potassium content of Ringer's solution must be considered in anuric patients and other patients where hyperkalemia is a risk. Glucose solutions contain no salt and are equivalent to giving the patient pure water. Therefore, they are not suitable in treatment of hypovolemia. Over-infusing the patient with isotonic salt solutions will expand the volume of the extracellular fluid without major changes in sodium concentration. There is volume overload with plasma sodium about normal. Volume overload occurs when the rate of administration exceeds the capacity of the kidneys to excrete the excess water and salt. This is especially grave in patients with renal failure. After trauma, including patients in the early post-operative period, there is decreased capacity of the kidneys to excrete salt and water. This is the reason that salt solutions in the first 24 to 48 hours post-operatively should not be given in big volumes except to compensate for existing losses. Most of the daily needs of water during this period are given as dextrose solutions. Because plasma sodium is about 145 milliequivalent per liter, for each liter of extracellular fluid losses or gain, there is about 150 milliequivalent per liter sodium loss or gain. The degree of hypervolemia can be estimated from the clinical signs, urine and blood tests shown in this slide. If the rate of development of hypervolemia was rapid, the heart is overloaded with extra volume and congestive heart failure develops. The added fluid will dilute the cellular and protein components of blood, resulting in decreased hematocrit. The treatment includes, of course, to stop giving sodium and to challenge the kidneys to rapidly excrete water and sodium by giving diuretics. If the kidneys are irresponsive, like with renal failure, and the pulmonary edema is severe, urgent dialysis will be needed. Thank you. We continue in part 2.